So what I want to tackle next, after having finished all this accelerator or linear accelerator business, I want to talk about other radiation or beam delivery systems in external beam therapy or in research. Some of the aspects that I explain on kV units, they of course also hold for research units like they are used in radiobiology. So you have radiobiology with Wolfgang Dörr, I guess. Yeah? I don't know how far he goes into the details, what he's doing with his cell line experiments and animal experiments, but all that is done with X-ray beams, and because their kV beams are the reference beam quality, and you have seen one of these fully shielded systems with Peter a couple of weeks ago. And at the end, I think I will not be able to get that far this time, but next time I will talk more generally about what is commissioning and what is acceptance testing. I attach this to this lecture, but in general, all these general views on acceptance testing, QA, commissioning, it also holds for accelerators. And cobalt units and kV beams are the kV units are the remaining units in external beam therapy. Again, some of the material I've taken from this textbook. I guess about all this historical background, I mentioned that already when talking about accelerators. I can skip that. There are various X-ray machines, and some of you, or I guess all of you, have seen that with the machines that we looked at the practicals. And all this history is of X-ray pioneers, and those guys that also started with radiotherapy and with imaging applications have certainly found
why is the Monaco product?
I have no idea why Monaco, but there is I don't know who is reading our, actually I don't know who is reading our journal of the German, Austrian and Swiss Medical Physics Societies, the Zeitschrift für medizinische Physik. There is because there is in the next issue there is a very nice historical article about all the things that happened prior. Röntgen found out something about the famous X-rays, and on the cover page of this next, it's the next issue. Yeah, there is a very nice picture from a glass window at the at somewhere at the Radium Institute in Stockholm, where this really looks like a church window with different colors, red and green and blue, but it's not from a church. And there you see Marie Curie, and there you see Röntgen holding an X-ray tube, and that's very fantastic, because all these pioneers have really at these days, yeah, found a lot of recognitions also in the society in general. You see that with the stamps. We also know this from the Nobel Prizes they were awarded with. Yeah. So, I mean, basically, this is all you know already with this, how X-rays are generated. And this is a more static accelerator than a cyclic accelerator that we have seen with the linear accelerator. And the principle, as we all know, didn't change a lot. I don't want to go into details here. I just wanted to remind us that besides all this Bremsstrahlung spectrum, we also have in these machines this characteristic X-rays, and there's another effect. One, you can have Auger electrons, but I guess you've heard about that during a basic physics study, but this is just a reminder. And yeah, one of the important aspects, I also mentioned it already, when talking about electrons, there are some things that we need to keep in mind, and that's why we have actually this beam quality specifier, like the TPR 20/10, the quality index for high energy photon beams, because the spectrum depends a big deal on the atomic number of the target, on the kinetic energy, also on the energy distribution of the incoming electrons, and on the thickness of the target. And that's why the same holds here for standard KV X-ray units, looking just specifying the beam by writing down the maximum accelerating potential is a very bad indicator of the beam that comes out. But this is basically some repetition. The range of electrons in the same way, electrons, at least if the target is very thick, yeah, can also penetrate and get scattering effects there, and then there can be certain depth where the Bremsstrahlungsspectra are really, or photons are really generated. And then if you relate the range of electrons with the target thickness, you can classify them as thick or thin targets. We have seen it also when talking about the accelerators. I mentioned that also in the practical session, this lower energy X-rays, we don't want to have that for therapy. That's why we use additional filtration. Remember these filters that we have to put in the X-ray unit, and without having the right filter and energy combination, we cannot switch the beam on. And these filters take off these low energy parts of the spectra, and we want to use the higher energy parts for therapy. I also mentioned already that this is an inefficient process in terms of heating, and here you see some relation between the incoming energy and what's converted to Bremsstrahlung and what is coming out in terms of characteristic photons. This is also something that it's a repetition from the accelerator part, where we have a different relation between the highest intensity coming out of the machine as a function of energy of the accelerated electrons, and due to this different angular relationship, we have different target orientations in the KV energy range and in the MeV energy range. Yeah, beam quality, I mentioned that already. So while we have tissue phantom ratios as the nowadays accepted beam quality specifier for high energy photon beams, at least in Europe. In the US, it's used, the PDDs are used. And there you can also look at the percentage depth dose, at the dose value at 10 centimeter and 20 centimeter, and use this ratio to indicate a number that is specific to a certain beam. This was used some decades ago, but it's bad. Complete spectrum would be the nicest thing, but that's hard to measure. And in KV unit and KV therapy, we use half-valley layers. Peter Homolka explained that already, so I can skip it, or yeah, so I can skip it. You know about the different energy ranges where aluminum and where copper is used? No, at least for our beams. No, because we have for, let's say, below 100 kV, in this range we use the material aluminum to specify the half-valley layer. For higher energies, it's copper that we use to specify. And besides aluminum and copper in radiotherapy for therapeutic units, no other material is used for specifying half-valley layers. So then I can go over that. You can read it back home. What I didn't mention, that's why I put that in, there are also some relations between PDDs and TPRs. So if you measure on an accelerator percentage depth dose curve, you can calculate that back to a TPR if you don't want to measure TPR. So there are some relations between these parameters. And then there is something else that we need to keep in mind. I don't go into any details about treatment planning and dose calculation for X-ray therapy, because that's really very simple. And from a conceptual point of view, when we do later on empirical dose calculation for photon beams, in the same way we can apply the algorithms and the same factors for KV beams. In the same way we can also build up an algorithm, a simple one, for electron beams. But there is one big difference between photon beams in the MeV and in the KeV range, and that's related to the absorption coefficients in this energy range. And so the dose is also proportional to the energy absorption coefficient. And that has there is a big difference in the KeV range between water and bone. And that's why when, for example, you treat a brain lesion or with a KV X-ray, you have really such a ramp up, and that's K stands for Knochen, sorry for the German word, that's water, L stands for lung, but that's why you have, and in KV therapy you can also get a lot of bone necrosis, because when you just look at the bone to dose to water or dose to tissue, then the dose to bone can be much higher because of this different energy absorption coefficient and the tremendous changes of this coefficient in this energy range. And that makes a big difference between this photon and the beams in the MeV and the KeV range. So this is something in terms of the interactions that you also should keep in mind. And so the depth dose curve, TD stands also for Tiefendoses, again, sorry, the German. For high energy photon beams, it's like this, and for X-rays, it's more like this. And then if you have disturbing material, disturbing in a way that it's different compared to water, if you look at the main tissues or density material that's different from water in the body, that's bone and lung, and the disturbance of the beam is very, very different in the KeV and in the MeV range. And that needs to be considered when looking at the doses at different parts of the body as a function of the depth dose curves. It's not only adequate to look at the depth dose, but you need to look at the material and take into account if there is bone, for example, somewhere there. Okay, now when looking at the X-ray machines, you've seen one machine. Our machine was a ceiling mounted, this is a floor mounted, so similar to accelerators. You can have here also various types. In our department we don't have a patient table, there is a patient table, so there are, at least from the concept, various differences. There are not so many companies anymore on the market providing this stuff. About these applicators, and that they have also here some heavy set material that acts as a primary collimator. We heard about that. I also explained these short treatment distances and the pitfalls of that, what can happen due to this inverse square law. When you look at the intensity in some way also at the dose, you can make big errors there. X-ray tube kind of cut drawing, a big difference. We also discussed about that already. In X-ray therapy we don't have a spinning target, we have a fixed target, and the focal spot size for these devices is much larger compared to the diagnostic X-ray tubes, because we're not using that for imaging. We want to have a high output in a short time in order to get a fast treatment. So it's a different concept. Yeah, these images I don't want to go into details. Similar what I've shown and explained for high energy photon beams. We're not using the whole Bremsstrahlungs distribution that gets out, but we have to cut out a certain piece of it, because in the same way like we want to have a flat beam in photon beam therapy, we also want to have a more or less flat beam. Flatness tolerances are larger there because we cannot get such a really nice flat beam as we can generate them with accelerators, but still the same principle holds that we only take a certain part of the spectrum for therapy. The classification of X-ray machines is not a very strict one. If you look at the borderline between the superficial and ultra voltage and also these contact therapy devices, if you look at different textbooks, there might be slightly different energy ranges, but you should keep in mind that there is contact therapy, there are superficial therapy units with this 3 or 4 centimeter typical source to surface distance, and then we have these ultra voltage units with providing the highest energies that we use with these machines for therapy. KV units, I mentioned that, radiobiological research. We use that in German-speaking countries quite still a lot for treating superficial lesions, for treating skin lesions, for treating metastases in a palliative setting if they're not too deep situated. In other countries, like Benelux area, it's rather electrons that are used, but we here in Austria, Germany, Switzerland have some tradition in using this kind of machines. Yeah, assessment of needs. Yeah, basically there are not so many manufacturers anymore because the need around the world is not really large, and like the machine that you've seen that we have for radiobiology research, if you order that, you have to wait 8 to 9 months because they are really produced on order. There is no market for that, so there are no machines on stock. So really the market is very limited. There are a few very new, or not very, but rather new. This machine is rather new. It's almost a decade old. The technology of these machines didn't change a lot, and this is a contact therapy device where you really have at the tip you have a gold target, and then the X-rays are more or less isotropically distributed around this X-ray target with a special arrangement. And this is used, for example, for treating brain lesions in a way. Where is that? Sorry. Here. Also in some stereotactic setting used by neurosurgeons, you get a stereotactic head frame and a Cartesian coordinate system is pulled over the patient, and then by using, of course, sophisticated treatment and planning and navigation systems, this is, for example, used for treating brain lesions, and this is a very specific contact therapy X-ray unit in a more modern setting compared to this other standard type of X-ray units. It's a very small device that can be even hold in a hand. So let's go back.
Why isn't it used further for intraoperative treatment in a typical brain tumor resection setting? Because you already have the radiation shield room for the intraoperative X-ray imaging. So why isn't it used more? It's the same KEV range, so you don't have to use extra shielding. What do you do? If you already have the room for CT or for X-ray imaging, is there any additional shielding necessary? Because in most neuro surgical settings, you have the room prepped for
Yeah.
X-ray or CT in a modern setting, for
Yeah.
normal CT. So is there any additional radiation protection necessary?
No,
In the
because
room,
that,
or-
I mean, that has I think up to 50 kV.
Yeah.
So and I also in this energy range, I guess, with wearing lead aprons and so on, it must be used in the same rooms because it's difficult to transfer the patients. And if you wanna operate these machines, it's I mean, with this type of machines, you're right. The radiation protection aspect is not the let's say limiting factor. It's more the classification of the operation theater itself. Yeah, if you open the patient, and usually when intraoperative radiotherapy is performed, that is only done in dedicated rooms. Yeah, that also have a certain class in terms of this classification of operation theaters. For example, in our department, we have 2 operation theaters. Have you seen that with Nicole? But we are not allowed, for example, there to perform intraoperative radiotherapy because the classification in terms of sterilization and so on is not high enough. I don't know all the details about these classifications, but I just know that there are differences.
Is the contact therapy useful? And is it useful?
I mean, it's used in some departments. It's not used here in our hospital, and in many aspects this depends a big deal on the training, yeah, on the experience of the neurosurgeon in this way, and I guess like with many other treatments, there are rival treatments, and it's one option. And it's an example of a more modern system, but it's not like this, that it's a standard piece of equipment in all neurosurgery departments. Okay. So, also with these X-ray therapies units, we have the same principle in terms of verifying the delivered dose. In the older machines that we had 20 years ago, it was rather a timer-based system for delivering the beam. Here we have in the more modern machines like the Gullmai system that you also saw. We have also a transmission ionization chamber. It counts kind of monitor units, and then you have this timer principle and this counting system with the primary monitor chamber, secondary monitor chamber, just like with the accelerators. Field sizes that they are limited, we all heard about that. Dose rates in standard ortho voltage therapy units, it's typically a few gray per minute. With this contact therapy units, it's much higher. There you have 10 gray, 20 gray per minute. Yeah? So that also means the dose is delivered in a much faster time. That also means reaction time, if something goes wrong, needs to be fast, or it's with superficial contact units, yeah, it's much different. About the Papillon technique, it's also something that it's just to remind you. We've heard about that in the practicals also. This Photon radiosurgery system, I explained it. Another application of this intraoperative unit, it's used also for treating breast cancer in an intraoperative setting, where the unit itself is the same. You have here different applicators with spheres of different diameters, and what you have around the tip here is really rotational symmetric dose distribution, isotropic, and the company producing the intrabeam device is called Zeiss. So from Zeiss you can buy this thing, and this is showing the principle of its application, where you need this special intraoperative applicator when you put this into the operation wound to get a fixed distance. around the target. Because if you wouldn't have such an applicator, you would have different distances from the tissue that you want to treat, which is the surgical bed, indicated here in red. And by having a fixed geometry, you can homogeneously irradiate these small layers of tissue. If you wouldn't have such an applicator, you would get a wild mixture probably of different distances, and there you would have a vast variation in the dose distribution. And this is this principle. And the modern unit that is from a German provider, which is called the Papillon machine, and that is with this upcoming Papillon technique for treating also in a contact therapy principle, rectal cancer or other skin lesions. And the interesting thing is that from a marketing point of view, this is called X-ray based brachytherapy. As you see it there, it's a copy of the flyer of this system. Treatment from a short distance, and bringing basically the target in contact with the lesion, and they call it brachytherapy in a way, or X-ray based brachytherapy. So this was just small excursion through the X-ray units, but most of that what you read actually is what I've explained during my 10-15 minutes during the practicals. Basic dosimetry. I forgot when putting the slides together that we are going to discuss about beam calibration from next time on, which is the 4th of December. And the next session, so chapter 5, will be about calibration of external beam therapy units, where I will cover calibration of photon beams, calibration of electron beams, also calibration of X-ray units. There we have a different principle, and also calibration of cobalt beams. And that's why I want to skip that, because next time we will go through this cookbook and recipe how to convert the measured ionization into an absolute dose. Yeah, I mean, maybe some general comments. I mean, of course, when you do dosimetry, you need to think first of all, what kind of beam do I have, and then you need to, let's say, also buy a kind of zoo of different dosimeters. If you have many different beam qualities, you might need a bigger zoo of those meters. You also might not only want to have a pointed detector to measure those in one point, but maybe you want to have a planar dosimetry system. There are several detector arrays. For beam calibration, we have standards for making absolute dosimetry, meaning to convert the output into gray. And there, the workhorse and the tool at the hospital level that's used is an air-filled ionization chamber. And this air-filled ionization chambers, in order to do a good beam calibration, they need to have a certain size. Usually that's about 1 cubic centimeter or a bit lower. 0.6 cubic centimeter, that's a typical standard chamber used for that purpose. And during the decades of establishing dosimetric procedures, all correction factors, it's not in a way that it's not doable with other detectors, but all the correction factors are most accurately determined for air-filled ionization chambers, including detector-specific correction factors. In these cavity theories, where we assume that we put a detector in our water phantom, and then we want to measure the dose that would be there if the detector wouldn't be there. So there are a lot of correction factors because the detector has a certain material, you still have a small cavity that disturbs the secondary particle fluence, and so on. And all these correction factors are best calculated for this type of chambers. And secondly, you need this, at least in the high energy range, you need these ratios of mass stopping powers, water to the material of the detector, or where these ionization effects occur. And they are also best calculated for air until to the I don't know how many digits, yeah, with the accuracy. And that's why for this beam calibration we can at the hospital level reach the best accuracy by using air-filled ionization chambers. And that's why this is the instrument that needs to be there for beam calibration in any way. And then you can also be clever or less clever by looking at the detectors that are more applicable for KV beams, for MV beams. You have different sensitivities in terms of energy, in terms of orientation, etc., etc. So instrumentation, whenever such a machine is put into clinics or into operation, when you need to do QA or calibration, is something that needs to be considered. Secondly, you need certain phantoms, because unless you're limited to X-ray beam therapy, there you don't need a phantom necessarily, because you can also do a lot of measurements in air with a build-up cap. But otherwise you need phantoms for measuring the doses not only in a point but in a plane, or making profiles, or making depth dose curves, and so on. And secondly, the ionization chamber needs to be connected to a reading device that's called electrometer. And when you want to do beam calibration, you need to get a calibration factor. And the calibration factor tells you how to convert your nanocoulomb into gray. So this calibration factor is specified in, I don't know, centigrade per nanocoulomb. And that is usually determined at the calibration laboratory. And this calibration factor holds for a chamber plus an electrometer. If you take a chamber with another electrometer, you might have a different calibration factor. That's why the chamber and the electrometer are always married with each other in some way. At least for beam calibration. And then for phantoms, you need to be sure that the phantom that you use for a specific beam has the same attenuation and scattering principles. And there are textbooks where you can find some recommended materials for different beam qualities. But for example, if you use PMMA for photon beams, it's quite okay, but PMMA is not okay for electron beams. If you look at the elemental composition and the number of electrons per gram and so on, that there is some big variations between all these plastic materials, but you can buy from providers of dosimetric equipment dedicated plastic materials that are called solid water. I mean, solid water doesn't mean ice, because that's also solid water, but it's a solid plastic material that has about the similar chemical composition like water, having the same scattering properties also as water, but you need to look whether it holds for the beam quality that where you want to do dosimetry. So there are also some pitfalls related to it. And why I'm always talking about these beam quality specifiers? Because when you get your calibration certificate, at least in Austria, your air-filled ionization chamber is calibrated in a cobalt beam, mostly. And then, if you do measurements in a high-energy photon beam provided by an accelerator, you have a different spectra, you have different energy beams and energy ranges, and then you need a correction factor that accounts that your beam is different from cobalt. And many of these correction factors, you find them in these cookbooks as a function of quality index. And then if you measure for your accelerator, your quality index, like a typical quality index for a 6 MV beam, it's 0.68, let's say 2. And then you can do some interpolation, and then you get your correction factor that you need to apply. And a similar principle holds for calibrations in the KeV beam range, and there you find a lot of correction factors that you need as a function of half value layer. And secondly, there are groups like larger medical physics groups in the UK, and they have published big books about reference data from scattering factors, depth dose curves for many different units. And they also have provided tables as a function of beam quality specifier. So there you find a lot of reference data how a beam with, I don't know, 3 mm copper half value layer should look like. And when you do measurements and you're all alone on an island with an X-ray unit and have this book, you can do your measurement, you can trust yourself, and maybe you did good measurements, maybe you did less good measurements, but then you have a comparison with your performance with the rest of the world, if you have no other colleagues to talk to. And also in this standard books with reference data, all reference data are given as a function of beam quality specifier, which is the half value layer for KV units, quality index for high energy photon beams, and R50 for electron beams. And without knowing these parameters for your beam, you cannot make the link to international standard reference books. That's why these beam quality specifiers are useful. Okay, now the last machine in external beam therapy is this famous cobalt unit. I've shown already some pictures. We had in our department some unit until the late 90s. From the mechanical design, it's looking very similar to an accelerator. It has a C-arm, it has a rotational gang, rotation table, and so on. Same treatment head with movable collimators, so very simple and similar principle. It was started in Canada because in Canada they had a research department that was able to produce cobalt-60, which is not a natural. You don't find cobalt-60 somewhere around the world in nature, but it's an artificially produced radionuclide. And what we use in cobalt therapy are basically the two gamma lines that follow beta decay, and the energy is 1.17 and 1.33 mega electron volt, and the half-life of cobalt is about 5 years. And prior cobalt came also in some parts around the world. In the early days of external beam therapy, cesium was used as in the same principle in terms of the mechanical construction of this cobalt device, but cesium has a lower energy, but still it was a bit of an advantage compared to the few hundred keV from also voltage units, but cesium units are, at least in the Western world, no longer used. Half-life also means that after one half-life, the treatment time doubles. So when you want to deliver a certain dose in a certain time, yeah, after one half-life it doubles. That means you have longer treatment times in the which might have an input on your patient throughput. Secondly, this intrafraction effects, that things can move, yeah. Patients are breathing, or maybe patients don't feel so well. It makes a difference whether they lie for 2 minutes or for 20 minutes on the table. And all these effects, of course, can play a role. And that's why, at least if the unit is heavily used, it's kind of common practice to replace the source after one half-life. In terms of external beam therapy machine and its mechanical components, you have a gantry stand, patient support, machine control, and the radioactive source is in the treatment head, and you need to have a source housing because with a radionuclide you have radiation all the time, but the patient needs to get on and off the table. We as radiation workers, also the RTTs bringing the patient into the treatment room, we don't want to be exposed all the time to the gamma rays from cobalt. So it needs to have a resting position, the source, that is sufficiently shielded or providing shielding for the source so the personnel is not exposed to radiation. Yeah. I will come back to the treatment head later. Compared to accelerators, Linacs have usually a greater depth of maximum dose. For typical cobalt beam, the depth of maximum dose is 0.5 centimeter. For a 6 MeV photon beam, it's about 1.5 centimeter. Linacs have smaller beam fall-off, so smaller penumbras, and they are accepted as being superior. We have faster treatments and we can do much more advanced radiotherapy, but that has nothing to do with the gamma lines or the spectrum of the provided by accelerators, but more with the construction of the unit itself. But on the other hand, it's cheaper, it's simpler, in some way it's more reliable, and then that's why these units are still often used in LMI countries, not developing countries. That's politically not correct, yeah? But one has to say low and middle income countries nowadays. But many of them are also pushing for accelerators because they want to compete with the rest of the world. You know that?
Yeah, but nowadays, if I take a simple Linux site, an Electra Compact, it's cheaper than a cobalt system.
Oh, really?
Yes.
I didn't know that. Yeah. But of course, in many of these countries, they're not seeing the same patients like we see. Yeah? So they have more advanced cancer types, larger volumes to be treated, and then more in a palliative setting, and then all these fancy therapies that I explained previously doesn't make sense. Yeah?
Well, I mean, the challenge is that the cobalt almost doesn't need any kind of maintenance, and the Linux writer needs maintenance.
Right, yeah.
That's the huge challenge.
Exactly.
For those countries, yeah. Because usually those countries don't invest in maintenance, they don't sign maintenance contracts.
Yeah, I know, yeah. But I didn't know that the simple accelerators are cheaper.
If you take Linux without the multi-leaf parameter, the cobalt doesn't have a multi-leaf either. If I take a similar configuration, then the Electra Compact is already cheaper than...
What's the price?
€500,000.
€500,000. And the cobalt?
It's depending on the configuration.
Yeah. And the cobalt?
As well.
Also €500,000.
Well, that's 0.6 million, like that. But it's well, the cobalt is just produced by there's a successor company for the Canadian, and there's the cobalt is produced in another one is produced in Prague. and still one has all the challenges basically to import the source and to replace the source after a couple of years.
Yeah. So the world is changing in that way, but still I would say 90% of the calibration laboratories around the world, cobalt units are used for all this calibration that needs to be done, so we can do our dosimetry on the LINAC, and these kind of institutions have cobalt units, but without all this patient support stuff. And by the way, did you see our calibration cobalt unit? No. Okay, but we can have a look at it next time. One challenge with the cobalt unit is also to provide sufficient dose rate, meaning to have sufficient radioactive material to have a reasonable treatment time. And in these cobalt units, we have source sizes of with a diameter of several centimeters and also several centimeters of height. And this has a big impact on the penumbra. I think I mentioned that already. And it doesn't make sense to, I mean, first of all, we cannot accept two big sources for penumbra reasons, but then there are also other reasons of related to the costs that are needed to produce these cobalt sources, which can be either small spheres or pellets, because of the self-absorption of the cobalt rays also along the height of the source. And this is just to illustrate you the principle that you can also calculate some effective activity of the source, but it doesn't make sense to build this endless long because of this self-absorption. Yeah, typical dose rates are also several grades per minute, but depends on the activity, and the activity makes also some impact on the price that you have to pay for a source. Source replacement after one half-life. I've mentioned that already. If the unit is not used a lot, one could also accept longer half-lives. And cobalt sources are also used in this neurosurgery device called Gamma Knife. I will come back to that when we're talking about advanced and precision radiotherapy techniques. And in that aspect, I will also touch stereotactic radiotherapy, and there we can perform stereotactic radiotherapy, high precision radiotherapy for small volumes with a LINAC or with such a Gamma Knife, and the Gamma Knife also uses cobalt. With a cobalt source, you have some shielding material. You will see that later on, and the source needs to be moved. In front of you also have some sort of primary collimator, just like the LINAC, and the source is moving in and out, and there are two principles: to have a sliding mechanism or a rotating mechanism, and the time that is needed from pressing the button beam on until the source is really in front of the opening, that is it's not going within microseconds, it's rather several tenths of seconds, and that needs to be taken into account also actually if you have very short delivery times, because if you want to treat only for, let's say, 10 seconds and you have half a second or a second of source moving time, this plays a role. If you have 5 minutes treatment times, then this shutter correction is not so important. And these are the schematic illustrations of these mechanisms. So this is a typical treatment head of a cobalt source from a side view, and this is a frontal view. This is a sliding mechanism, and this is a rotating mechanism, where when you press the beam on, here is the source, the whole thing moves, and then you have the source in front of this primary collimator and opening, and here you have the slider. You have seen a light field on the accelerator? Yes, no? Yeah? And in the same way, like you have a light field, meaning a bulb, yeah, that is really providing light that you see where the treatment field would be. In the same way, you have also light fields here with cobalt units. Yeah, this is not an illustration, but really an in-scale drawing of this Teratronics unit with this rotating mechanism. And here you see depleted uranium is used here to provide sufficient shielding if the source is not in the position for therapeutic applications. And this is a French unit, the Zero system, that doesn't exist anymore. They also use depleted uranium, and they have this sliding mechanism. About the shutter correction, I mentioned that already. This is not so important. I mean, the isocenter principle, like from an accelerator, the same holds for a cobalt unit. Cobalt unit had in some way also one peculiar characteristics. Some units, and there you could spare some concrete for the shielding of the primary beam. They had something what's called a beam stopper, which also first of all provides a counterweight to the treatment head, which is then a bit simpler for the mechanical balance of the whole machine. And then if you load this also with lead, you can get a kind of attenuation of the beam, and that can reduce the costs for a treatment room in terms of shielding. And this beam stopper was also something specific for cobalt units. It was used in some centers. Yeah, and then cobalt units were somehow disappearing from industrialized countries, from Western countries, and there were a couple of papers on how the world is going to continue with cobalt or not, yeah? And redesigns of modern cobalt units were discussed, and then actually until very recently nothing happened. And in some way cobalt was then declared to be dead. Counterweights and so on. Yeah, this is how a more modern cobalt unit looks like. Also with electronic control, similar to an accelerator from the outside. It could be also an accelerator, very similar. Yeah, about the timer principles, I mentioned already these dual monitor chambers with accelerators. The nice thing with radioactive sources is you can really calculate the treatment time in terms of seconds, yeah? Because there is this decay law, and you can use that to relate treatment time and dose, and this decay is rather very, very stable, yeah? And here you really press in, I don't know, 36.5 seconds treatment time or something like that, but still you have a secondary timer, so you have some security mechanisms if this primary timer doesn't switch off the beam in a similar way like the primary dose monitor chamber in an accelerator. And about the shutter correction, that's something that I mentioned already. This is the time that's needed to move the source to the opening, and that needs to be considered in the whole treatment time calculation, but you can do that nicely in an electronic way. About the larger penumbra related to the source size, that's also a review. I think I've mentioned that already, and there's source size differences between cobalt of having, let's say, 2 centimeter diameter and 2 millimeter focal spot size of an today accelerator. That makes the difference in the penumbra. That has nothing to do with the, let's say, the beam itself. It's rather the construction of the source. Yeah, and then cobalt was declared to be dead, yeah, and then many different concepts were at least published and put on paper on how for several radiotherapy and precision radiotherapy applications, similar to this tomotherapy where the accelerator is turning around the patient, a similar concept, or was also proposed having more than one source, similar to Gamma Knife. There you have 200 cobalt sources, but some of these concepts were proposed, but none of them was realized until recently. Because this kind of machine, the ViewRay system, which is a combination of an MR scanner with 3 cobalt units that are related to each other at an angle of 120 degrees, was brought onto the market. And with this device, the new, let's say, an upcoming field of MR-guided external beam therapy is explored. So these systems are already used for patient treatments in the US and in Europe, in Italy, to demonstrate that MR image guidance, irrespective of the cobalt sources, provide an added value compared to image guidance that is provided by today's state-of-the-art Linux with KV imaging. So, 10 years ago, cobalt was declared to be dead. Also, in terms of MR imaging, low-field MRs were declared to be disappearing, and now we have in radiotherapy an MR cobalt unit with a cobalt and a low-field MR, and that's used in daily practice. Of course, the field shaping has changed, and here on all these 3 different cobalt units, you have multi-leaf collimators that also enable some sort of intensity modulation, that enable also arc therapy, rotational therapy, and with, of course, image quality and soft tissue contrast, and also the speed of imaging is better if you use higher field strength. But still, if you compare low field MR images, they have superior soft tissue contrast compared to cone beam CT X-ray images. And we don't use these images for diagnosis, but we use it for anatomic image guidance. And that's a different application of this imaging. So, but that is something like the most modern MR unit that is now available and used in some places around the world.
Do you know the orientation of the magnetic field or the MRI?
I can look at, I mean, probably if you Google ViewRay.
Well, you can't do that, then just communicate just in the line of the patient, because otherwise.
So it's, I would assume from, if these are the magnets, it's like this, in this direction.
Is it the set direction?
Yeah.
It's
Right into the patient.
Yeah.
Excellent. One question there is noted that cobalt 60 is used for total body irradiation.
Yeah.
So does that mean, for example, fighting leukemia?
Right, yeah. So total body irradiation, I mean, you can do that in many ways, and there are many different treatment concepts for total body irradiation. And I think you've seen our moving bed. Yeah. So what we are doing is we move the patient while the beam is on. Even with a maximum collimator opening, you cannot reach the whole body. And for example, a colleague of mine, they have a department in Jena, and they put the cobalt source. I mean, there's really somehow, it was a very interesting thing. They really took the whole C-arm, cut it off here, and installed it at the top of the treatment room, in some corner, and then they had also a standard accelerator in the whole bunker, and then by just using the different geometry, they could perform total body irradiation with the cobalt unit, and the patient was lying there. but you can do similar principles but with the patient moving.
It's a very important
Yeah.
patient.
Sorry?
Has to be. Obviously, it was a very important patient because.
No, I mean they used it for many patients.
Okay.
I mean because it was a fixed installation. Another principle of doing total body irrigation, you can turn the gantry to 90 or 270 degree, and then put the patient on the wall of the other side of the treatment room and treat the patient in seated or lying position. Yeah. Also total body irradiation. I will talk about that in not next semester, but in about a year. When talking about all these, let's say, very specific techniques that we're using, and there I will give you a more detailed overview about all the different, we call it TBIs or total body irradiation, about the different TBI techniques and concepts that are used. Yeah. Okay. Yeah. Shielding considerations, it's also something that I mentioned already. Unless you're using such a beam stopper, you have for cobalt units similar considerations as for a LINAC. It's the same what the primary barrier and the primary beam is. I mentioned that already. Same principle here. Yeah, treatment rooms. What else do I want to say? Yeah. This is something that you should keep in mind with cobalt. Not because I probably won't ask that, yeah, but having somehow passed at the end of your ULG, the ULG, cobalt is a important radionuclide in radiotherapy. The same holds for iridium-192. The rest is something that you can forget about, but these two you should at least keep in mind in terms of what's the range of the half-life and what's the range of the energy. That's what they want to, yeah. And then, yeah, this is something that is not so important. Here again you see the difference influence of the cobalt and the LINAC source dimension, and also for performing IMRT and performing highly sophisticated precision treatments, you want to have a steep dose gradient between your organ at risk and your target, and that's why we assume we want to have a very steep penumbra. Is that really true?
Do we want it or
we
have it?
We have it? No, we have it, yeah.
Yeah.
That's, but is it always really good?
No, because you're asking.
No, I mean it can be good, yeah?
If the different planning system is capable to calculate the adequate dose, then what can we cope with?
Yeah, but
Being,
let's assume that's there.
but being able to draw sharp lines,
Yeah.
because that means that having sharp slopes can not be a disadvantage.
But there could also be cases where you really want to use the penumbra. Of course, it's not that a sharp line, and you have some kind of a modulation of the beam intensity.
You don't think it matters for conformal treatments?
Why?
Because in density modulated treatments, we optimize with what we have.
Yeah.
We probably also, yeah, we see that this flattening people treatment, the quality can be.
Yeah, that's an argument, yeah. Now, what I wanted to say and what I wanted to point out, yeah, with all these very fantastic and high precision treatments, we also need to have a fantastic and high precision target. And if one...
The patient.
What?
You mean the patient?
No, I mean the planning target volume, yeah, and all these volumes that need to be also, the more precise we are in terms of beam delivery, the more precise our colleagues from radiation oncology need to be in terms where they draw the border, where they want to have a dose and where they don't want to have a dose. And if you don't know really where's the border where you have probably no microscopic spread anymore, or where you don't want to have a dose. Yeah, if you have here a little bit of a wider penumbra or a lower dose, yeah, and maybe you have less target cells, yeah, that still get the dose, might contribute to a treatment. But the more precise you are, in missing something that's not drawn for whatever reason. Because you don't see it, your colleague was not trained, your colleague has overlooked it. Yeah? So, and this precision goes not only with beam delivery, but it starts with the whole time that's taken to make, to define your target, where you want to have a dose and where you don't want to have a dose.
Another question: how fast is the temporal resolution and the ratio between being able to rotate the patient, being able to move the patient, and being able to make a shutter of the cobalt? So could you fractionate really in
No, I mean that needs to be done with the collimators, yeah, with the multi-leaf collimators, and because I never thought about that actually, yeah, but I don't want to move the source more often than necessary, because all that's a mechanical thing, and one of the worst thing that can happen is that the source got stuck. And I mean, it happened in our department twice in the 20 years, at least that I remember. And then, if the source got stuck, you need a volunteer. Or two. Yeah? To get in, get the patient off from the table.
How fast does one have to react in this case? Very fast.
Yeah.
Yeah. Yeah, but what's the time frame to decide? So, how long is the
Yeah, I mean, if there is the dose, the point is, if it's hard to say, because you don't know whether the source is partially back, whether it's still full there, and so as fast as possible. And the whole thing is a matter of training, because if the source got stuck, the thing that shouldn't happen is that the person's realizing that is calls to superiors. What should I do? Yeah?
The Austrian way.
The Austrian way. Yeah, because
Let's
one
write
needs
an
to
email.
react, yeah? And then you need to think about that also, yeah? To perform training with all the personnel, because you don't know who is there. I mean, the RTDs should be there, but also physicists. I mean, you need somebody to go in, yeah? To get at least the patient off. Yeah? If there is a patient in the mask system, yeah, you need to free him or her and get it out, then even if you don't want to put the source back. But then there are but we had also some kind of mechanical tools that need to be inserted, and then with
blocker.
With some physical force you could turn on these emergency buttons and situations to get the source back. And all that is for brachytherapy. It's the same way. I mean, if the source doesn't move back, you need to do something to get it back. So you saw an afterloader with this wheel and so on, and then you saw the container, so, and the tweezer, to grab the source. So 1/r² distance in practice. So this is also something that needs to be considered, and with this events that can happen with radioactive nuclides, also our radiation protection authorities were not really happy with these cobalt machines, and they were pretty relaxed when the last cobalt machine disappeared in Austria. And the next thing that needs to be considered also with the source replacement. I mean, there were, with the diminishing number of cobalt sources, there were less and less companies who provided source exchange. it was not only the companies that provided these cobalt units, there were other specialized companies. Then the cobalt sources need to put somewhere on a radioactive waste place. Then all these companies needed to have the license to transport the sources. I'm not allowed. You've heard something about the ruthenium applicators. So we have beta emitting sources that are used in brachytherapy to treat eye lesions. And this is a beta ruthenium 106. So it's a small applicator like this, and it's in a lead container. It's maybe double of the size of this bottle. So I can take it in my car and transport it, I don't know, somewhere. But I don't have the license to transport radioactive source. So all these things, of course, also play a role when dealing with these sources. And okay, penumbra considerations is something that I mentioned already. Yeah.
You just said with the cobalt sources, someone has to get in to get the patient out. But in case the patient is not fit, would you just tell him over the microphone to get out?
No, because we are responsible for the patient. Penumbra. The penumbra aspects related to source sizes. I mentioned that more often than in the last minutes, but in the case we have blocks, and in some ways blocks are still used. And for example, for in some places for patients with lymphomas or so, we have very, very strange irregular blocks that are formed according to the lymphatic system. And these very irregular blocks are not so easy to, or blocking is not so easy to adjust with multi-leaf collimators. So some centers still have these handmade blocks. And another aspect that determines penumbra, if blocks are used, linked to the fact whether the blocks are divergent. So when performing and cutting or molding these blocks, these beam divergence need to be taken into account in order to get the best penumbra that's possible. And if you would need just standard blocks, here you would also have some scattering effects, and then also you might have some ray lines that still are able to penetrate the small distance of the block, and that also contribute to some dose outside of your fields that you want to treat. And there is some differences in this that you see here in this isodose lines, whether you have a divergent or a non-divergent block. This is a comparison that you can't forget about. A thin edge shaft, whether it's good or bad. I mentioned that already in terms of target definition. In terms of penumbra, I want just to draw your attention again to that there are different isodose levels than you can look at. And sometimes you find textbooks or publications that express the penumbra but don't tell you what isodoses are, or maybe you are comparing the two different isodose levels that are not matched to each other. So this is just to make you aware that there are different definitions used. Yeah.
There isn't any big sense in making the penumbra even sharper than today? Is it correct to say, from the view of clinic? If I understood correct?
It's still our ambition to do so. I mean, like also with this dose painting that I mentioned, also with adaptive radiotherapy approaches, but also when you look at particle beam therapy, or if you look at brachytherapy, where you have also few spots where you put your radioactive sources, you can get very deep dose gradients. But what needs to be taken into account when delivering steep dose gradients is my treatment geometry reliable in terms of beam positioning? Very precise dose delivering without having a precise target doesn't make sense to me. Yeah? And the next thing is, if you cannot guarantee the geometric and anatomic position, then you might be even more in danger because you might miss the target. And that is also something that's criticized, that we have coned down our volumes and we don't have the long-term outcome, because usually a patient is followed up a couple of years from a radiotherapy department, and then the patients are not coming to us anymore. So after 3 months, after 6 months, after 1 year, but then after, let's say, 6, 7, 8, 10 years, usually cancer patients don't go to radiotherapy department, but maybe to other specialists in internal medicine. So even if something happens with the patient, it's maybe not all known in radiotherapy. So the long term, if you change something, you will know that only in 10 years. And we don't practice our very sophisticated treatments for such a long time to know all that. What's done. The next discussion that is coming also with all this image guidance, we give, and like when we're doing cone beam CT on a daily basis, we have a lot of low dose volume, not only in the place where the cancer is located, but also to organ at risk. So nobody knows what's the long-term effect of all these low doses to bigger volumes by performing imaging. That at least comes from the radiation protection people. And one of the challenges is that, you either hear that or heard that from Wolfgang Dörr, that is the long-term, the late toxicity that requires a detailed follow-up. And like with breast cancer, did I mention the heart toxicity to you, or because I don't want to repeat myself and bore you? No? Like with and then there are some countries, and unfortunately Austria is not such a country where that is so well organized in terms of patient follow-up. And what is discussed in Austria, that we need cancer statistics and so on. Other countries like Denmark, they have a big cancer statistics and follow-up, a closed follow-up of patients since the mid-80s. So what we're discussing has been implemented there 30 years ago. So they have a very good knowledge, for example, how different changes in practice in chemotherapy, in radiotherapy practice, for example, had an impact on the survival of head and neck cancer patients, which is really fantastic, and not only from 100 patients, but from thousands of patients. Or the Scandinavian countries, Norway and Sweden, have very good registries of breast cancer patients, also with a detailed follow-up. And usually, after 5 or 10 years, patients, as I said, are no longer followed up. But they have done this, and they have found out that breast cancer patients with a left breast cancer, after 15 to 20 years, they have a higher risk for becoming a stroke because of the irrigated heart. And there is obviously some vessel damage, and you only find that if you have such good databases, and some of these effects appear much later than was assumed 10 years ago. And in order to do something for us and also for the researchers in 10 years to work on these databases, we need to start now to create these databases. Otherwise, we cannot make progress. And then we need to find a consensus, not only in Austria but around the world, what to record. So what to write down in a patient chart. Yeah, if all departments doing something different, we have a cocktail of parameters that are not comparable. And this is something in terms of also, I think we as medical physicists having some clue about dosimetry, dose values related to imaging and so on, we need to give advice in order to establish these databases for our current and the long-term future.
Actually, I guess with the Euratom directive, it should then be done with 2018 because they demand to record all those references of those values for also for imaging for all patients for 10 years.
I wanted to directly also add something to that because a normal thorax CT and in an intensive care unit, and they get it every day or every second day. And you have thorax CT, it's 40 millisieverts or something like that. If you do transfusion, even more.
Yeah.
So that is really something relevant.
Yeah.
But what should be implemented with 2018?
But no, but the point is the following: that in many of these, let's say, also radiation protection authorities, it's in radiation oncology we are somehow having a different position because our patients have cancer, yeah, and then this extra dose, yeah, is somehow not so much considered, yeah. I mean, on the other hand, we are also in a difficult position because we do imaging during therapy, and then there are all these factors how you can convert your dose, let's say your exposure, yeah, to millisieverts and so on, but all that's radiation protection factors. And then if we perform, let's say, 40 times a cone beam CT, we get extraordinary numbers. But then, if you add some other those contributions from diagnostic radiology, what the patient has already received during diagnosis, and then if patient is going to another department for follow-up CT scans, in our radiotherapy community, we only see our dose, and then there are some people making a lot, not only noise, but fear. But just looking at our imaging dose and completely neglecting what's happening with the patient before and what's happening with the patient afterwards. And I think we need to bring all that together. That's my point. Yeah?
We'll need medical physicists in the radiology department, as I see in mine.
Yeah.
And the RTs that are doing dose management now would be completely overwhelmed by doing this OCT, for example, but there's so much dose accumulating there.
Yeah.
Do you think that there will be additional medical physicists be needed for that?
It's written in the EU directive.
Yeah.
You need to have a medical physicist, so that's
I think it's
June 2008. Really?
Yeah,
So
yeah, it's
medical physics expert really demanded.
yeah, it's coming. It's in this 174.
Yeah, I forgot the number.
Yeah, it's and it's coming in.
June 2018. Am I right?
Yeah,
So the
theory.
directive is out there. It has to be local law, implemented in local law with 2008.
Yeah. I'm not, well, I hope it will be implemented in time, but because I think I was mentioning the Euratom guideline 9743. And I think this is the...
I think there is just one big and they now
Yeah,
put everything
exactly,
together.
because that is...
Medicine, radiology,
Yeah,
also
but that wasn't the
radiology,
same for
everything in one.
Euratom guideline 9743, but still it was becoming a real Euratom guideline in 97, and the Austrian radiation protection legislation was published in 2001, so only 4 years later. So
This is yours.
it's the Austrian way, yeah. That's why I don't know whether 2018 is a hard date.
28 maybe.
Tentative date. Okay, so about these other depth dose considerations, I will go into let's say, more discussion with you about that and about the commissioning and acceptance testing next time. And want to thank you and break up for a coffee break or whatsoever there is now. Thank you.
Ich habe eine Frage. Die Total Body Irradiation